Good day, everyone. This is Sir Franz, and I'd like to welcome you to our last unit for this semester. And our first lesson for finals will be developments in the therapy of congestive heart failure. So I hope you have already watched the primer lecture that I uploaded. And to recapitulate that lecture, we have here a slide showing to us the agents with mortality benefit in congestive heart failure. If we say mortality benefit, that means that if the patient takes these classes of medication, it will translate to an increase in the lifespan of that patient. So first we have beta blockers, and the primary mechanism for that is a decrease in myocardial oxygen demand because of a decrease in heart rate and force of contraction or inotropy. Inhibitors of RAAS, renin, angiotensin, aldosterone system, all in all inhibit the remodeling of the myocardium. So these include ACEs, angiotensin converting enzyme inhibitors, which will decrease the levels of angiotensin 2, angiotensin receptor blockers, which will prevent the binding of angiotensin 2 to its receptor, and aldosterone antagonists, which, as the name implies, will prevent the binding of aldosterone and its subsequent effects downstream. The third class of agents would be a combination of hydralazine, an arteriolar vasodilator, and nitrate, which is a venodilator. And all in all, it decreases preload and at the same time afterload. And lastly, we have new agents that have been found to decrease mortality in patients with heart failure. These are your SGLT2 inhibitors, sodium glucose cotransporter 2 inhibitors, which will prevent reuptake of glucose in the proximal convoluted tubules of the kidney. So, as logically, this would mean that these are agents that are used to treat diabetes mellitus, but they found out that in patients who have concomitant congestive heart failure and diabetes mellitus, the use of SGLT2 inhibitors decreased mortality in those sets of patients. Lastly, we have a combination of ARB and Neprilysin inhibitors. Neprilysin, again, is an enzyme that prevents the breakdown, Neprilysin is an enzyme that facilitates the breakdown of brain natriuretic peptide. So if you inhibit neprilysin, that will lead to higher levels of BNP. This slide shows us the physiology of brain natriuretic peptide. So we start first with plasma volume expansion. So if the plasma volume increases, the preload or the venous return increases. And so there will be more blood stretching the walls of the right ventricle. And in response to that stretch, the right ventricle releases brain natriuretic peptide. After releasing brain natriuretic peptide, it will cause a decrease in the activity of the sympathetic nervous system, a decrease in blood pressure, a decrease in aldosterone, a decrease in the afferent tone to the kidney, and an increase in the efferent tone, which, all in all, will increase the glomerular filtration rate. And this will lead the kidney to eliminate that excess water. And all in all, your brain natriuretic peptides are natriuretic peptides, which would mean they will cause the kidneys to eliminate sodium and at the same time water. Here we have a slide showing the site of action of our new agents for heart failure. These are very potent agents that can be used in patients who have acute exacerbation of heart failure. So these are our angiotensin receptor neprilysin inhibitor. So they are called ARNIs in the hospital. So you have here the natriuretic peptide system, and you have here your natriuretic peptide being broken down by Neprilysin into inactive fragments. So if you recall the last slide, you have to remember that natriuretic peptides help decongest the patient from heart failure. So if you inhibit Neprilysin, then that will lead to higher levels of your natriuretic peptides, and that will lead to natriuresis and diuresis. So you eliminate the water and the salt. That will lead to vasodilation, which eventually will lead to decreased blood pressure. And because there is decreased stress on the endothelium, that will lead to a healthier endothelium. There will be decreased hypertrophy, decreased fibrosis, and these are processes that lead to heart failure. These are processes that we call cardiac remodeling. Neprilysin inhibitors will also cause a decrease in sympathetic outflow. So remember, with decreased sympathetic outflow, you will have lower levels of cardiac inotropy and cardiac chronotropy. So that will decrease myocardial oxygen demand. So like exercising muscles, if your heart is rested, it will not need to grow. So that is the principle behind inhibiting cardiac remodeling. At the other side of the image, we have RAAS and its effector angiotensin II, which is a very potent vasoconstrictor, leading to vasoconstriction, an increase in blood pressure, and endothelial remodeling. It also causes hypertrophy and fibrosis because the heart would have to pump against non-compliant systemic circulation. It also causes an increase in sympathetic outflow. So if you inhibit RAS, you decrease the activity of angiotensin II, combine that with a neprilysin inhibitor, which will bolster the activity of brain natriuretic peptide. And now you have here a very potent agent for the control of heart failure. These are what we call ARNIs. And lastly, it may be unique to think that an agent that is used to treat diabetes mellitus can be a life-saving medication for the treatment of congestive heart failure. So here we have a slide showing to us the effects of SGLT2 inhibition. So first, you have here an image of the nephron, and you have here a portion of the nephron, the proximal convoluted tubule. Take out one cell, and this is the image that we will see. You have here the side of the urine and the side of blood. So here in the side of urine, SGLT2, sodium glucose cotransporter 2, will cause the reabsorption of both sodium and glucose. So if we have a drug that will inhibit the reabsorption of sodium and glucose, these two molecules will remain in the urine. So if we don't have the ability to reabsorb sodium and glucose, that will decrease the workload of the kidney. So hindi siya masyadong mapapagod kasi hindi niya kailangan i-reabsorb yung dalawa. And that will lead to a reduced consumption of ATP and relative hypoxia in the renal cortex. So if the proximal convoluted tubule cells will use less ATP, that will decrease the stress onto these cells and cause the reversion of myofibroblasts to erythropoietin-producing fibroblasts. You have to remember that the kidney produces erythropoietin, which stimulates red blood cell production in the bone marrow. So if we decrease the stress on the kidneys by preventing the reabsorption of sodium and glucose, the kidney will produce more erythropoietin, and that will increase the hematocrit of the blood. the blood will simply have more red blood cells and more cells carrying oxygen. Increased sodium and glucose excretion will lead to an increased glucagon to insulin ratio, which means in the pancreas, there will be higher levels of glucagon relative to insulin. And once that happens, that will set up lipolysis or the breakdown of fat. If lipolysis, of course, you will have weight loss. If um, you have increased lipolysis, you will also have decreased insulin resistance, and that will lead to an improved glycemic control. Decreased glucose in the blood will eventually help the endothelium and blood vessels become healthier. Next, because you have eliminated sodium and glucose in the urine, that will cause solute diuresis, which would mean inside the tubule, the sodium and glucose will pull the water into the lumen, and that will decrease the plasma volume. And with decreased plasma volume, there is less force acting against the endothelium, and that will have improved endothelial function. And all in all, it will reduce blood pressure and help the heart because systemic vascular resistance has decreased. The heart would not have to pump really hard and will not have to undergo cardiac remodeling. Diuresis will also cause a reduction in ventricular preload, so decreased stretch of the ventricles, therefore decreased stimulus for remodeling. So with all of those mechanisms in mind, remember again what the agents that reduce mortality in heart failure patients are. These are your beta blockers, ACE-ICE, ARBs, aldosterone antagonists, hydralazine plus nitrates, ARNIs, and SGLT2 inhibitors. So with that, I hope your knowledge of pharmacotherapy in heart failure has improved this time. Thank you for listening.